So hi everyone. Thank you for giving up your free time to come and learn about our research on the important but often understudied topic that is suicidal ideation. And today I'll be presenting some of the findings that beg the question, are we missing vital opportunities to prevent not just deaths by suicide, but also other deaths in individuals who present to emergency departments with suicidal thoughts? And hopefully by the end of this presentation, I'll have convinced you that the answer is yes. So before we dive into any of the findings, it's important to make sure that we're all on the same page about what we mean by suicidal ideation. Simply put, suicidal ideation refers to thoughts about ending one's life, but as with most aspects of mental health, it's not quite that simple, and it's not a one-size-fits-all concept. Suicidal ideation exists on a spectrum. So on the one hand, you have passive suicidal ideation, which involves thoughts about death or wanting to die, but without specific plans or intent. And then on the other hand, you have active suicidal ideation, which involves more concrete thoughts or planning. This could involve thinking about specific methods or having a definite plan. So it's a step further along the spectrum and generally indicates a higher level of risk. It's important to note, however, that individuals can move between these states. Someone might experience passive ideation that later becomes active, or vice versa. And this fluidity underscores the importance of ongoing assessment and support. And understanding suicidal ideation is absolutely vital if we want to be able to prevent suicide. It's not only a recognized precursor to suicide, but it's also surprisingly more common than most people would think. So about 9% of the global population will experience suicidal ideation at some point in their lives. And even more striking is the fact that about 30% of those will go on to attempt suicide. So by deepening our understanding of suicidal ideation, we can gain important insights into the pathway from thoughts to actions, which is obviously key if we want to develop more effective prevention strategies and interventions, potentially saving lives before a crisis point is reached. So the problem is that ideation research is notoriously challenging for a whole host of reasons. We're dealing with a complex issue that's often stigmatized, making it difficult to study effectively. And the nature of suicidal thoughts means that they're challenging to define consistently and even harder to measure accurately. Funding for this type of research can be limited, which further complicates our efforts, and the sensitive nature of the subject matter introduces important ethical considerations that researchers must navigate carefully. So all of these factors combined mean that there's a scarcity of representative population-wide resources on which we can conduct this research. And this has been a significant barrier to understanding the full scope and nature of the issue. However, Northern Ireland stands out in this regard. Now, it's not often that something positive comes out of Northern Ireland. Sinking ships and sectarian violence come to mind. But I'm very proud to say that we have something that no one else in the world has, and that is the only registry in the world to capture national data on suicidal ideation. And it's very aptly named Northern Ireland Registry of Self-Harm and Suicidal Ideation. So the registry captures data on all individuals who present to the 12 emergency departments in Northern Ireland with either self-harm or suicidal ideation. And this unique resource, when combined with our ability to link individual level data for the whole population, offers us an unparalleled opportunity to study ideation on a population-wide scale, offering insights that simply aren't available elsewhere. So with this data at our fingertips, we set out three main objectives. The first was to examine the characteristics of those who present to emergency departments with suicidal ideation. Second was to quantify the risk of suicide and other causes of death among those who present to ideation, or who present with ideation. And the third is to identify the factors within those presenters that may increase mortality risk. And to achieve these objectives, we employed a data linkage approach. So we started with a population cohort of all individuals aged 10 and over, on the 1st of April 2012, which we drew from GP registration data. And we were then able to identify those who had presented with ideation from 2012 onwards using the Northern Ireland Registry of Self-Harm and Suicidal Ideation. And finally, linkage of death records meant that we were able to compare mortality outcomes between those who had presented with ideation and those who hadn't, as well as conducting a more in-depth analysis of the risk factors for mortality exclusively in those who presented with ideation. So each individual was followed up from April 2012 until the end of 2019, meaning that we had a maximum of 7 years follow-up. So our study drew data from 4 main data sources: GP registration data, from which we extracted our population spine, as well as some basic demographic information, such as date of birth and sex. The General Registrar Office, which supplied death records. The Northern Ireland Neighbourhood Information Service, which gave us some area level information, including income deprivation and settlement band. And of course, we had the Northern Ireland Registry of Self-Harm and Suicidal Ideation, which was crucial in identifying our ideation presenters. And linkage across these data sets was made possible by the presence of the health and care number. And this is a unique 10-digit identifier against which all health and social care contact in Northern Ireland is recorded. So in spite of what this graphic suggests, our final cohort consisted of more than 3 people. In fact, we captured just over 1.66 million. And of these, we observed 30,000 presentations for suicidal ideation by 15,267 individuals. That's about 1% of the population, a small but significant group, as we'll see later. So our first research objective was to try and identify those who are most likely to present with suicidal ideation. And we looked at several risk factors, including age, sex, income deprivation, urbanicity, and living alone. So let's take a look at what we found. When it came to age, we found something quite striking. Nearly 40% of those presenting with ideation were aged between 10 and 24 years old. And then from there, there was a gradual decrease in the likelihood of presenting as an individual's age increased. And in contrast to what we'd normally see with the likes of self-harm, it was actually males who made up the majority of ideation presentations, with about 3 in every 5 presenters being male. And this observation persisted even when we ran our logistic regression model, looking at the likelihood of presenting, adjusted for all other characteristics. So we found that males were 61% more likely to experience ideation than females. So this challenges some common assumptions that we have about mental health and gender. Perhaps unsurprisingly, we find a strong link between income deprivation and ideation. You can see a nice linear increase in the proportion of those presenting with ideation as you move from the most affluent to the most deprived areas, with about a third of those presenters coming from the most deprived quintile. And when we controlled for everything else, again, we find that those from the most deprived areas were twice as likely to present with ideation compared to those from the least deprived areas. And it's a stark reminder of how social and economic factors can impact mental health. Interestingly, the vast majority of those who presented with ideation were living in intermediate areas, so that encompasses the smaller cities and towns in Northern Ireland, with a further 29% coming from urban areas and 24% from rural areas. However, it was actually urban dwellers who had the highest likelihood of presenting with ideation when we accounted for the within-group numbers and other covariates. They were twice as likely to present with ideation compared to those in rural areas. And this may play into the fact that the urban environments are typically associated with poorer mental health outcomes. Living arrangements also played a role. Despite only making up 15% of presenters, individuals who lived alone were twice as likely to present with ideation. And of course, it doesn't mean that living alone causes ideation necessarily, but it does perhaps highlight the importance of social connections in maintaining good mental health. So to sum up, the most important risk factors for presenting with suicidal ideation that we identified were male gender, being aged under 25 years old, city living, living alone, and social deprivation. So we've identified the factors that are associated with ideation itself, but do these factors play a role in actually influencing the risk of death after presentation? You'll have to wait until later to find out. First, we need to take a more general look at mortality and how this varied between ideators and the general population. So over the course of follow-up, about 117,000 cohort members died, which is equivalent to about 7% of the cohort. And of these, just over 1,000 had previously presented with ideation. And that's about 1% of total deaths. A small number perhaps, but as we'll see, it tells an important story. So this bar chart shows the percentage of the total deaths that were observed in ideators compared to the general population. So as we saw on the last slide, ideators accounted for 1% of all deaths in the cohort, 8% of external causes of death, and 12% of all suicides observed were in individuals who had previously presented with ideation. And considering that ideators only made up 1% of the whole cohort, that is a really significant proportion. When we ran our survival analysis, we found that those who had presented with ideation were 3 times more likely to die from any cause, 10 times more likely to die from external causes, and 10 times more likely to die by suicide. And I think it's important to remember that these aren't just statistics. These are real people who have sadly lost their lives. And these figures underscore the critical importance of addressing suicidal ideation. But suicide isn't the only outcome we need to be prioritising. 20% of those who died from drug-related causes had previously presented with ideation, and just under 10% of those died from alcohol-related causes had previously presented with ideation. In fact, drug-related deaths actually carried the highest single risk estimate across the whole study. We found that ideators were 15 times more likely to die from drug-related causes and 10 times more likely to die from alcohol-related causes. So this suggests that when we're dealing with suicidal ideation, we need to be thinking about substance use as well. So up to this point, we've been looking at the population as a whole. We've identified the risk factors for presenting with ideation, and we've quantified the overall risks of mortality in ideators compared to their peers who didn't present with ideation. So the next phase of this study involved zooming in exclusively on ideation, the ideation group, to see if we could identify who among this already high-risk group was at the highest risk of mortality. And the risk factors that we examined were the same as in the previous section, with the addition of 2 presentation-specific characteristics. And that was whether an individual had consumed alcohol prior to their presentation, the number of times that an individual presented with ideation during the study period. So looking at demographics, we find that males were at a higher risk across all 3 primary mortality outcomes. But interestingly, gender didn't significantly influence the risk of drug or alcohol-related deaths. Age played a complex role, with risk patterns varying depending on the specific cause of death. The risk increased in a linear fashion for all-cause deaths and alcohol-related deaths, but external and suicide deaths, we observed the highest risks for those in the 25 to 34 age category, which mirrors trends in suicide rates. And living alone was only a significant risk factor for all-cause deaths. So interestingly, where someone lived seemed to have less impact on mortality risk than it did on the likelihood of presenting with ideation in the first place. So in contrast to the steep social gradient that we saw earlier in terms of the likelihood of presenting with ideation among those living in the most deprived areas, deprivation didn't significantly influence the risk of any death outcome except for alcohol-related deaths. And surprisingly, those living in the most deprived areas were actually less likely to die from alcohol-related causes. Urban dwellers had a slightly higher risk of all-cause mortality, But for other outcomes, including suicide, location didn't seem to play a significant role. So now we get to move on to a variable that we haven't encountered yet, and that is recurrent ideation. And we found that about 1 in 3 individuals had more than one presentation for ideation over the study period. However, it was only a significant risk factor for alcohol-related deaths. So individuals with multiple presentations were 1.37 times more likely to die from alcohol-related causes, highlighting a potentially complex relationship between recurring ideation and alcohol consumption that warrants further investigation. So speaking of alcohol, we find that 40% of individuals were under the influence when they presented with ideation. So this speaks to existing research that suggests that alcohol can impair judgment, increase impulsivity, and diminish an individual's ability to cope with stressors, potentially leading to a higher risk of experiencing suicidal thoughts. But does it actually influence mortality risk? Well, the answer is we find that individuals who consumed alcohol prior to their ideation presentation had a higher risk of all-cause mortality and were nearly 4 times more likely to die from alcohol-related causes. But surprisingly, it had no impact on suicide risk. So one of our most important findings was about the timing of deaths after presentation. As you can see, the risks associated with all causes of death were highest in the months immediately following presentation. And when we looked at suicide in more detail, we find that 36% of suicides occurred within 6 months of presentation, 50% within 12 months, and 63% within 18 months. So this really underscores the importance of timely assessments and the provision of follow-up care in the days immediately after an ideation presentation. So what are the key takeaways from these findings? Well, one of the most important observations is that individuals who present with ideation have a much higher risk of suicide, 10 times higher than the general population. Importantly, 12% of all of those people who died by suicide in the whole of Northern Ireland had previously been seen at an emergency department for suicidal thoughts. And this highlights a crucial opportunity for an intervention that we're currently missing. However, the risks aren't limited to suicide alone. We observed a higher risk of death from other causes, particularly those related to substance use. And this suggests that our approach to ideation needs to be holistic, addressing not just suicide risk, but overall health and well-being. In the months immediately following an ideation presentation emerged as the critical period. This is when interventions are likely to have the most impact, emphasising the need for robust follow-up care. And lastly, we find that demographic and socioeconomic factors influence risk in complex ways. And this complexity underscores the need for nuanced, personalised approaches to intervention and support. However, I do think that there is hope in these findings, and that lies in the fact that emergency departments provide a rare opportunity for intervention in a population who are typically very hard to identify and for whom there may be significant barriers to seeking help. In particular, emergency departments can facilitate the provision of comprehensive mental health assessments and referrals by specialist psychiatric teams, the management of co-occurring issues like substance misuse, and perhaps most importantly, the initiation of long-term care plans. So, in essence, emergency departments could effectively serve as a gateway to comprehensive mental health care, which should in turn reduce preventable deaths. However, the emergency healthcare system as it is now isn't properly equipped to manage patients who present with suicidal ideation. Unlike with self-harm, there are currently no standardized guidelines for the management and recommended best practice of care for individuals who present with suicidal ideation. So this is a significant gap that needs to be addressed. Healthcare professionals are in need of guidelines that include assessment protocols, intervention strategies, and follow-up care recommendations. So in combining our research findings with existing literature, there are a number of recommendations that have been shown to improve outcomes. First things first, comprehensive mental health assessments at the point of presentation in emergency departments and establishing follow-up care plans before discharge are fundamental in reducing the number of preventable deaths. These measures would ensure immediate support and continuity of care for individuals in crisis. There's also clear rationale for the development of NICE guidelines to ensure standardized evidence-based management of patients similar to existing guidelines for self-harm. The research also indicates that mental health training for ED staff is a must. Many healthcare professionals, while extremely skilled in dealing with physical health emergencies, often lack specialized mental health expertise. So equipping them with these skills could significantly improve patient outcomes. And lastly, studies point to a need to address the siloed nature of our healthcare system. Improved cross-sectional collaboration and communication between emergency services, mental health teams, and primary care providers is a must-have for providing integrated support. And this approach could help ensure the patients receive consistent, coordinated care across different healthcare settings. But while these recommendations are grounded in research, it's important to acknowledge the complex reality of our healthcare system. We're facing severe underfunding and unprecedented levels of staff burnout, particularly in emergency departments. And these systemic issues create significant barriers to implementing change, no matter how evidence-based our suggestions might be. So any real progress will require addressing these underlying problems first. So we're actively trying to translate these findings into real-world impact. So far, we presented our results to the all-party group on suicide prevention at Stormont, which brings together members of the Northern Ireland Assembly, as well as representatives from mental health organisations, with the overall objective of encouraging discussions regarding issues relating to suicide prevention in Northern Ireland. The Assembly members were highly engaged and responsive, and one member even expressed interest in pushing for legislation to encourage wider access to healthcare data for approved research projects. And I think they really recognise the potential that's held within our data. Building on this, we also intend to launch a Delphi study. This will bring together a group of experts focused on identifying evidence-based recommendations for managing suicidal ideation presentations. And it's hoped that these will help to contribute to the development of NICE guidelines. We're also embarking on a new all-encompassing research project that will expand on our current findings, allowing us to delve much deeper into the complexities of self-harm and suicidal ideation. However, this time we'll be capturing all the available data and variables held within the registry, including information on mental health assessments, and we'll all be going a step further by linking additional data sets, including data on mental health inpatient admissions and receipt of prescribed medications for mental illness. And of course, we've also published our findings, so if you're interested in reading the full paper, you can either scan this QR code, or I'm sure Emma will put the link in the chat, whichever you prefer. Before we wrap up, I just have to acknowledge the invaluable support that we received from the Honest Broker Service, the Public Health Agency, and the Health and Social Care Trusts. This research would not have been possible without their cooperation and assistance. And finally, I couldn't possibly end the presentation without acknowledging this lovely gentleman who sadly lost last year. Dermot has really done so much for administrative data research, not only in Northern Ireland, but across the UK and further afield. And he played such an instrumental role in raising me to be the researcher that I am today. Sadly, this is the last study that we ever worked on together, but I can guarantee that he's looking down over us all now, judging my presentation skills. I think that's a very fitting end to the presentation. Thank you all so much for coming to your